Welcome everyone. Today's fantastic afternoon and so good response from all of you taking time out from your busy schedules. Welcome to ADC webinar 211 to be presented by esteemed speaker Dr. Abhaydeep Singh. It's my immense pleasure and privilege to introduce today's our esteemed speaker for today's webinar, Unleash the Power of Corticals, Immediate Functional Loading and Protocols. Our speaker, Dr. Abhaydeep Singh, is a passionate and dedicated implantologist who has been practicing implant dentistry since 2016 with a special focus on corticobasal and bicortical implantology. Over the years, he has developed a deep understanding of the science and biomechanics behind immediate loading protocol and has earned recognition for his expertise in design and application of cortical anchorage systems. Multiple systems he has been practicing. Dr. Abhaydeep has completed his fellowship in Bi-cortical Implantology, FBCI, and has continuously refined his skills by attending advanced workshops and training programs. Both nationally and internationally, he has a keen interest in the biomechanics of implant design, a field in which he has devoted considerable time to understanding how implant geometry and cortical anchorage influence long-term clinical success. This unique perspective enables him to simplify complex cases and achieve highly predictable immediate loading outcomes. Beyond his clinical practice, Dr. Abhaydeep is actively involved in advancing implant education and professional collaboration. He currently serves as the Chief Operating Officer of the Corticocore organization and is the Director of the Organizing Committee for ICORE 2026, the International Congress Oral Rehabilitation and Excellence, to be held in Jaipur during November 2026. One of the most anticipated academic platforms in the field of implant dentistry it is. A strong believer in evidence-based dentistry and continuous learning, Dr. Abhaydeep is deeply committed to mentoring fellow clinicians and helping them master the principles and practical applications of modern cortical implantology. His vision to empower dentists to confidently adopt immediate functional loading protocols and deliver life-changing results of their patients. Today, he will be sharing his valuable insights and practical strategies on how to truly unleash the power of cortical anchorage and harness the full potential of immediate loading in everyday clinical practice. Please join me in extending a warm and enthusiastic welcome to our speaker for the afternoon today, Dr. Abhaydeep Singh. Welcome, sir. Over
Thank
to
you so much, sir. Thank you so much for the great introduction. Thank you, Sudhir, sir. And I truly appreciate truly appreciate this opportunity that you are giving me to speak about the my favorite topic that I love. And I really hope that people enjoy this topic and they try to take home some key points from this. And I hope they start learning this immediate functional loading protocol. And
Sure,
let's
sir.
start with the PPT.
Yes, sir.
First of all, I'll extend my heartfelt thanks to ADC, Dr. Sudhir, for giving me this opportunity. And I hope the participants are either well versed with the dental implantology field or they are practicing themselves or they might be practicing cortical implantology already. So I do not intend to make you learn everything in this slide, but I can only make you see that what could be possible. Whosoever is not practicing immediate functional loading, who is keen on practicing conventional implantology, who is still afraid of going inside the corticals, I hope you take home a few key messages that what can be possible, what can be done, and if we get out of the conventional traditional ideology of conventional loading or giving 3 to 6 months, maybe 1 year for loading the implant, the fixture that we give to the patient. The world has gone far beyond these timings. People are getting into the implantology in where you give the implant and the tooth over it in a single day, or maybe even in an hour also. With the current scenario of 3D printing and milling, in-house milling, people have their milling machines inside the clinic. So they just give the chairside immediate temporary or permanent which can be loaded functionally almost immediately. So let's start with the topic. So if cortical bone is nature's strongest architectural framework, why do we still rely primarily on cancellous bone? We were taught in our colleges, in our books, there's no mention of corticals, no mention of cortical loading, no mention of cortical engagements. We have always been taught about the alveolar bone. We have always been made to see the cancellous, the soft, the spongy bone that there is around the tooth. So it is not our mistake actually, but the books need to evolve, the science needs to evolve, and this science need to enter the academics also. So what we usually do and what we were taught to do is that you do osteotomy, put the fixture, and then you close the site, and then you wait for the remodeling to happen. We wait for the bone to interact with the implant surface, whatever it is, even if it's smooth surface, rough surface, single piece, two piece. We were made to learn that we need to wait for the remodeling to complete. We need to wait for the primary mineralization to complete. And then when implant is well osteo integrated, now remember this word osseointegration has been taught to us since ages. It's been there in the books, and we have always learned about osseointegration only. Now you can say that this could be marketing, or this could be implant companies that who are forwarding this word to all the dental surgeons. But osseointegration now in today's world, it's a traditional word. We do not primarily depend upon osseointegration nowadays. We do not depend upon time process, the remodeling process to load the implant immediately. We definitely do not want to wait, because the patient has come to you for the tooth. The patient is not asking for the titanium. Patient is not asking for the fixture. Patient is not asking for the implant. Patient is asking for the tooth. If there's a missing tooth in the interior, you would give an immediate aesthetic loading. That is called aesthetic loading, because you do not want the patient to bite over it. You do not want the patient to chew from that tooth. So we have always been afraid of giving a molar immediately, right? We would never load the implant that is put in the sixth region or the seventh region in the posteriors. We would never want to load it immediately, because we are afraid that the implant might fail. And which is definitely true, because we are placing that fixture in the cancellous bone, in the alveolar bone. The remodeling process of the alveolar bone is entirely different from the corticals. We tend to forget that the bone all over in our body is covered by this thick cortical lining, which is relatively stable, which is relatively more dense and more mineralized. So if you fixate your implant in that dense cortical bone, you can load your implant almost immediately, and that loading would be functional. We would not want patient, we would not tell the patient to have a liquid diet for 1 month or 2 months or 3 months. We would ask the patient to start chewing from it almost immediately, because we want the cortical to respond back when we chew when we chew food from the prosthesis on the implants that are fixated in the cortical bone. The cortical bone has a nature of thickening itself against the stimuli. So this, I hope that you understand this science from this masterclass or this 1 hour webinar. Now, the problem is, why does immediate loading fail? If you put the implant in the alveolar bone, which would demand complete time for osseointegration, which would have to undergo remodeling and the bone resorption, bone formation process, and then mineralization, and then the secondary mineralization, the hardening of the bone around the implant. The peri-implant bone has to be highly integrated with the implant. For that, you need time. You need to give it time so that the bone responds properly and it integrates properly with the implant. So if you load that implant, which is right there in the alveolar bone, there is micro motion. If there is movement beyond 100 to 150 microns, at the implant bone surface, it would disrupt the clot formation and it would prevent osseointegration. This is the only reason that we do not load the posteriors immediately, because we know that the patient would bite upon that tooth and there will be micro motions, and then the implant would fail, or the implant might go into fibrous union. The osseointegration process would be hampered if there is any point where the implant is interacting with the bone through a fibrous union. Now, we might achieve primary stability. This is not completely accurate because primary stability can be from two or three bone walls only. You might achieve 40, 45, 50, 60 NCM torque. The ISQ value, the primary stability for the two-piece implants is usually lower than 16 for the 60 for the two-piece implants. ISQ for these cortical implants is relatively higher. We go beyond 70, 80, 90 and achieve high primary stability in the cortical bone. Now, if you have good primary stability and you load it immediately, the functional loading upon that tooth would ultimately hamper the remodeling process. The bone has to go under remodeling, the bone has to resorb first, and then only there will be bone formation, and then there only will be osseointegration. Now, if you load that implant immediately, functionally, the primary stability is going to go away and there will be bone loss. There will be crestal bone loss. Now, poor primary stability means that it is not beyond the ISQ value of 60. Crestal bone loss would happen because of the micromotion at the abutment implant interface. Biological incompatibility is the cancellous bone with its loose trabecular architecture cannot withstand immediate functional forces. If there is cortical engagement, you can load that implant almost immediately. The only particular over here is the cortical engagement. If anybody has any kind of question, please ask me right away, or you write it in the chat and I'll try to answer that at the end. Okay. The traditional delayed loading philosophy. We place the implant in the cancellous bone. We close the flap. First of all, we raise the flap and then we place the implant. That only triggers the inflammation process. And then this stability dips. The osseointegration process, the bone remodeling process starts. First, in the initial days, in the first 1 or 2 weeks, there is resorption of the bone. The woven bone transition vulnerability window starts, and then the bone around the implant, at the bone implant surface, at the bone implant junction, bone starts to, it starts, the osteoblast starts making the bone around it. The initial bone that is made after the fibrin is dissolved is the woven bone. The woven bone is a very soft bone. You cannot load it. You do not want to load the soft bone because that might get converted back into the fibrous union. That might result in the fibrous union of the implant with the bone. Now, you have to wait for 3 to 6 months. You want that woven bone formation around the implant to get converted into the lamellar bone. You want lamellar maturation, you want osseointegration, then only you'll get the confidence of loading that implant. Because ultimately you have to load the implant. You cannot wait longer and longer. You cannot keep on asking the patient to avoid the loading for another 2 months or another 3 months or another 6 months. You have to ultimately load the implant. And that confidence would only come that if there is no fibrous union around the implant, if there is proper osseointegration around the implant. And that would take 3 to 6 months for sure because the bone physiology has to respond accordingly. You have placed the implant in that soft, spongy alveolar bone where the bone remodeling would take its time and then only primary mineralization would happen. Now, the difference between the alveolar and the cortical bone is quite clear. Now, alveolar bone is predominantly trabecular architecture, whereas the cortical bone is dense lamellar bone. Is high vascularity. That remodeling, the bone remodeling process can only occur if there is vascularity. The higher the vascularity, the higher the sponginess of the bone, there is higher vascularity and hence the higher remodeling there is. Cortical bone has a relatively lower vascularity, hence it is more stable. The remodeling process is relatively slower in the cortical bone. The cancellous bone being spongy and this soft bone it has poor mechanical strength under load. It cannot withstand high forces. It cannot withstand high pressures. Cortical bone being highly mineralized, dense, it can take exceptional mechanical forces. You can stand, you can only stand if there is corticals around your long bones. If there's no cortical around your long bones, you might not be able to stand, right? Your muscles and your corticals work synergistically to make you stand, to make you stick, and they make you walk. This cancellous, the medullary, the spongy bone do not take much mechanical stresses. These are susceptible to disuse atrophy. When there is loss of tooth, the alveolar bone tends to go away. The bone loss that occurs is in the alveolar bone region only. You have never seen anybody with missing jaw, right? The jaw never goes away. The mandible always stays. There is always mandible around. There is always cortical bone that is left behind after the teeth are lost and the alveolar bone is gone. Am I right? And then this cortical bone, it maintains its density with functional loading only. There is muscle attachment around the corticals, and if there is teeth present, or if there is any implant present, the bone tends to stay. The bone doesn't go away. Now, immediate loading is not a protocol. It is a biological consequence of engaging the right bone. You can load your alveolar bone as well, but your alveolar bone might not be able to take all the functional stresses. This makes absolute right sense. And cortical bone, which is highly mineralized, which is highly dense bone, if you engage your implant inside that highly dense cortical bone, mineralized bone, then you need not to depend upon the alveolar bone only. You are getting the primary stability from the cortical bone. You are transferring all the stresses, all the forces, all the occlusal forces right towards the cortical bone. Your alveolar bone is not taking the primary stresses, the primary forces, and it can take all the time that it needs to complete the remodeling process, to complete the primary mineralization process, and then ultimately osseointegration or osseoadaptation will take care of the secondary stability. You just need to take care of the primary stability. And in this cortical bone, when the implant is engaged in this highly mineralized bone, you get the primary stability of about 70, 80, 90, and sometimes you are not even able to measure it, because most of the times you are placing your implant with the hand grip. You might not be able to measure the torque immediately, but you get the idea of it that this is going to go beyond 90, 100. So only the cortical bone is able to take this kind of high torques. The implant stability quotient, that ISQ value, that is way beyond the primary stability ISQ in the conventional implants, which I told you that this is lower than 60 in the alveolar bone. The strategical cortical engagements, you get the ISQ value of 70 to 85 and maybe more beyond that, right? So it becomes the stable bone, which is not going to go away with the functional forces. It is going to stay. The remodeling process, the remodeling rate in the cortical bone is way lower. So when you get the higher ISQ value of 70 and beyond, maybe 80, 90, 100, you tend to eliminate the micromotion. The micromotion is only you can eliminate completely. Now that splinting of the implants could be with this intraoral welding. You can load the implants with the rigid processes that are PFM and zirconias. You can give a milled titanium bar to rigidly splint all the implants. You can give immediate processes to splint the implants, and that processes should not be a soft plastic processes. It should be hard metal or titanium or zirconium. The best way to do that is intraoral welding, right? This immediate functional loading within 24 to 72 hours might be a blessing, or एक इसको मजबूरी बोल सकते हैं, that we have to load it within 72 hours because the remodeling process in the cortical bone is slightly different from the alveolar bone. After 72 hours, the osteoblastic and osteoclastic activity starts. The bone resorption around the implant thread starts. We do not want to load the implant in that window. We do not want to load the implant when there is the bone resorption is happening around the bone implant interface. Now, biological adaptation via mechanotransaction, this is the bone reaction. How your bone reacts to your implant surface. There's a theory given by Dr. Harold Frost. He's a great this orthopedic surgeon, and he has given the theory of rapid acceleratory phenomena. Whenever you give a stimulus to the bone tends to react. It has to react any kind of stimulus. When you extract the implant, when you extract a tooth, when you put an implant, when you do osteotomy, if there's a fracture, if there's any kind of trauma to the bone, that is kind of a stimulus for the bone. That stimuli triggers a phenomena, rapid acceleratory phenomena, in which the bone remodeling and the bone resorption and bone formation is happening. This bone resorption and bone formation, this tends to end up with the osteoadaptation. The bone adapts around the threads of the implant that are engaged in the cortical. Now, that osteoadaptation allows the secondary stability to come for the longer health of the implant. Someone is drawing these lines and stars over the screen. Please remove these. Sudhir sir, can you stop this line drawing and stars on the screen?
Yeah, actually, sir, I was also looking for why it is happening. It is from my side. Wrong way.
No,
Okay. I'll remove him. Okay. Rangveni, Dr. Rangveni is doing it, I think, by
I
mistake.
think some child is there on the screen, or maybe
Yeah.
someone has the access to the phone.
Multiple access I have given now. That's why.
Okay.
I'll remove him. Just change the slides, sir, please.
Okay. I'm unable to remove these drawn stars and lines.
Oh, okay, I think it is. I have removed them already. I'll check with the multiple sharing. I'll stop multiple sharing. But then आपका चलना चला जाए सर एक सेकंड.
नहीं, मैं इसमें इरेजर से कर रहा
हाँ,
हूँ जहाँ जहाँ से।
अच्छा रेजर. एटलीस्ट अभी तो शेयरिंग नहीं है मल्टीपल. ओनली वन sharing is allowed. That is you.
Okay. I'm just erasing all these.
Okay.
Just give me a minute. I want all of you to understand this completely because this is not rocket science. This is very easy, and this is there in just in front of you, and we are not taught to see the cortical bone. We are never trained to see the cortical bone. We are just trained to see the alveolar bone. We remove the tooth and we try to place the implant right in that length only. We are afraid of going beyond the inferior alveolar nerve. We are afraid of going beyond the sinus. We are always afraid of getting into the sinus. We are always afraid of even touching the nerve. Sometimes there is no bone left, there is no alveolar bone left, and you have promised the patient that you are going to put an implant and give a tooth over it. And then when you see the OPG or the CBCT, there is no bone left. Then what do? You might refer to the person who is doing grafting, the ridge splits, and the autograft, xenograft, allograft, whatever you want to do, or maybe sinus lifts to increase the alveolar bone. The world is changing. You need to see beyond this. There's no need of sinus lifts. There's no need of splitting the ridges to increase the width, to increase the length. You do not need this kind of extensive procedures. And because if you, even if you do sinus lift, you have to wait for another 2 or 3 months. You cannot just load it immediately. You just put the implant and then you pray to God that this bone forms over here. You have put the graft and you pray to God that this graft converts into bone. This is not how it happens. Bone graft is just a scaffold. It will just hold the blood clot. The graft in itself would never convert into the bone. And even if you give a autograft, imagine explaining it to the patient that you are going to take a chunk of bone from their, tibia or fibula, and or maybe the ribs or the chin, but wherever you want to harvest that graft from, and you explain it to the patient. That patient might be, that patient might get scared. The patient might end up getting a RPD. They'll ask you to give a removable prosthesis. So you need to learn, you need to train yourself how to engage the bone when there is no bone. You need to learn how to say yes to the no bone cases. When you yourself or your radiologist have examined your CBCTs or OPGs and told to you that there is no possibility of placing an implant because there is no alveolar bone left, you need to see that what there is left and what we can utilize to place the implants. All of you must have seen zygomatics and pterygoids, and that is an excellent classic example of cortical engagements. And but we have never imagined, we have never thought about it. We just call someone who is trained to do zygomatic implants, and we are happy to pay them 10x the prices. You all should be trained yourself to engage the corticals. Zygomatic is also a cortical. Pterygoid is also a cortical, right? So, moving forward, the bone biology. We all know bone is a living organ. Beyond the rigid scaffold, what all there is vascularity, there is cellular orchestra, there are signaling networks, there is neuromuscular bundles inside it, there is Haversian system inside it, there is osteoblast, osteoclast balance is there. There is bone remodeling all of the time that there is going on in your body. The 10% of your skeleton remodels annually. Imagine 10% of all the bone that there is in your body, it gets changed every year in everybody without any exception. This rate might be a little bit higher or lower in adults or in children, or in, if there is any kind of metabolic disorder. If the patient has osteoporosis, then the bone resorption might be more. But everybody of us tend to lose 1 to 2 mm of bone every year. This is a calculation of bone formation and resorption. This is occurring simultaneously all the time in your body. Even walking, even standing, even sitting, it is kind of a trigger. That is kind of a stimulus to your bone. Your bone will respond immediately. Even if you are sleeping, your bones are taking the weight of your body in the supine position. That is also a trigger for the cortical bone. The cortical bone is always responding to the triggers. But this trigger is so small, that this stimulus is so small, that the response is also very small. The bone remodeling is always going on in your body. The level of bone formation and resorption, that calculation ends up how much bone you are going to lose every year. All right. Now, what are the osteoblasts? We have always studied during our UG or PG time that we have read bone physiology very well. We are well versed with the fibroblasts, osteoblasts, with the osteoclastic activity, osteoblastic activity, the fibroblastic activity. So I'll just try to tell you the superficial knowledge of this. I'm not going to go deep because this would become boring for many of you. And obviously, because of the shortage of time, this would just take 3 to 4 hours just to explain this bone remodeling unit to you. So just going superficially, osteoblasts are the cell that form the bone. Osteoclasts, on the other hand, these are the remodeling engines. Osteoclasts are the precursor cells. Beyond this, there is activation process, then there is resorption process, and then there is bone preservation or bone formation process. Osteoclasts are the precursors. Osteoblasts are the bone forming cells. Osteoclasts are the bone resorbing cells. Osteoclasts come first when there is any kind of stimulus in the bone. Your bone reacts via osteoclasts. The signal is given to the osteoclasts and they start resorbing the bone around that stimuli, around that trauma, around any kind of extraction. Even if you have done extraction, I'm not talking about implant placement over here. I'm just taking an example of extraction. If you extract one tooth from the mandible, your whole mandible, I'm going to repeat it, the whole mandible, not just that the local site, the whole mandible goes under remodeling. And that remodeling takes about 1 year to settle down. The initial mineralization happens in initial 1 or 2 months. Then there is a lag period. After that lag period, the secondary mineralization occurs, and that is a very, very slow process, and it might take more than 1 year to complete. So I usually tell my students all the time that the best time to place the implant is on the day of extraction. At my clinic, the number of extractions done is equal to the number of implants placed. Obviously, leaving the exceptions where we have to remove the wisdom tooth or there is no need of any replacement. Otherwise, where there is the need of replacement, we place the implant on the day of extraction because we do not want to trigger remodeling again and again. We do not want the bone to start resorbing the bone again and again. Then it would take more time to mineralize. It would take more time to complete the remodeling process. The osteoclastic activity, we do not want to trigger it every day. We do not want to trigger it while there is bone formation process going on. Now imagine you have extracted a tooth on the first of the month and patient tells you that I'll just get the tooth extracted, then I'll make up my mind, I'll talk to my family members, and then I'll come back and then I'll ask you to place the implant. Now imagine that you have extracted the tooth, you have triggered the osteoclastic activity, the bone is starting to resorb after 2 days, 3 days, and the patient has come to you back on seventh day and they have told you that doctor, I have decided finally to go for the implant. You just place the implant and then I'll wait for another 2 or 3 months so that you can load it. Now imagine going again inside that bone, triggering that bone, inducing osteoclastic activity while there is osteoblastic activity going on that seventh or eighth or 10th day. The osteoclastic activity ends after a few days and then the osteoblastic activity starts because where there is bone resorption, the bone has to form. You cannot just the bone cannot just resorb. It has to maintain homeostasis. It has to maintain that value. It has to bring that bone back. It has to deposit more minerals. It has to make that woven bone so that the calculation sets right and you end up losing only 1 to 2 mm bone ultimately. For that, the bone formation has to occur. This is how remodeling works. This is called bone homeostasis. Now, imagine you are going inside that bone where the bone has just started to settle down. The bone has just started to, the osteoblastic activity has just started, and you then again go ahead and do the osteotomy and you place the implant, and then you again trigger that osteoclastic activity. While the bone is forming, you are again triggering bone resorption activity. Do you think that kind of stimulus to the bone would end up in implant success? That would technically lower down the rate of success for your implant placement. So the best day to do any kind of stimulus is the day when you plan to do the extraction. It is not right, it is not justified biologically, biomechanically that you do multiple type of stimulus at variable time periods and then you expect success out of it, right? The osteocytes, these are the bone mechanosensory network. These are the triggering networks. Now, osteocytes are settled inside the cortical bone. Cortical bone has the densest osteocyte canalicular network in the skeleton. And when an immediately loaded implant transmits force into the cortical bone, what happens then? The fluid flow stimulates osteocyte process, the sclerostin. Just take a screenshot of this and you can read it afterwards. I'll just try to explain it in a very smoother way. I would not like to read all the slides because it will become boring that way. Now, when the osteocytes are triggered, this is what leads to the pathway activation. The pathway of the osteoclastic and blastic activity, the hollow canal formation where the osteoclastic and blastic activity is going to occur in a simultaneous way. The osteocytes give a stimulus which enables the pathway, and then new bone formation initiates around the implant. Okay. Now, what is Wolff's law? I'll explain it to you in a very, very easy way. You can just take the screenshot of this and read it afterwards. Whenever there is stimulus, whenever there is a stimulus directly directed towards the corticals tend to react with cortical thickening. When you give pressure, when you train your corticals, when you train your, it is just like your muscles. You just do resistance training in at the gym, and you see that there is muscle thickening, muscle growing, right? So this is the same law that is reflected in the cortical bone. When there is occlusal forces, functional pressure that is reflected to, that is directed towards the cortical, the bone tends to thicken. The bone tends to, there is more bone formation, there is more bone mineralization that is going to occur over a period of time, not immediately after the stress, but it takes time. The remodeling process, I have told you the remodeling process is always going on inside your body, which is reacting to the any kind of stimuli. Even if you are walking, even if you are sitting, that is kind of stimulus to the cortical bone. Now imagine the cortical bone is already being trained by our muscles. Where are your muscles attached? It is always attached on your mandible and the masseter, the buccinator. They are all attached. The muscles of mastication, they are all attached on the corticals. The outside bone, the outer shell of your mandible is cortical. Anywhere in your body, the outer shell is cortical, the inner shell is the cancellous or the spongy bone. Now imagine the corticals are thickened, already thickened with the training that they are getting from the muscles. You are speaking, you are eating anything, you are drinking water, your mandible is moving. All this movement is reflected upon the corticals, and the corticals tend to thicken in reaction to that stimuli. Now you have lodged to implant in that cortical, and the forces that are going to be directed inside that cortical, it is also kind of a stimuli which is to which the cortical bone would react equally how it reacts to the muscular pressure, the muscular pull and push. So whenever there is disuse, whenever you use the bone less, there is atrophy that is going to happen. But if there is a continuous training of the cortical bone, continuous forces directed towards the cortical bone, it tends to thicken over a variable period of time. I have just explained this thing. This is Frost's mechanostat theory, and he has explained it very well with this mechanostat theory. The Wolff's law has been explained very well with this. Now, the bone remodeling cycle, I've told you, this is same thing. First, the activation occurs whenever there is stimulus, whenever there is any kind of trauma, whenever there is any kind of insult to the bone. And that could be a tooth extraction, fracture, any kind of osteotomy that you do for the implant placement. That is also kind of an insult. The stimuli that is going to be there in the bone. This is how bone reacts. First of all, there is activation. The lining cells retract the osteoclast precursors, and then the bone resorption starts. Bone resorption happens. Which cells start the resorption process? These are the osteoclasts. Osteoclast activity causes resorption, osteoblastic activity causes bone formation. Now, after this resorption process, there is a reversal. There is reversal of the pathway. The osteocytes that are interacting with the osteoclast to resorb the bone, there is reversal and the osteoclastic activity lags down. Then the osteoblastic activity starts. Now, there is a small lag period. There is 2 to 3 week lag period after which the bone resorption starts, and then there is process of primary mineralization. Primary mineralization is what? Nothing but the conversion of that smooth woven bone into the lamellar bone. The trabecular patterns start settling in a parallel way, in a more organized way, and there is more calcium deposition, there is more mineral deposition, there is more mineralization of that bone with time, which ultimately takes 2 to 3 months. Now, this is the exact period where we load our conventional implant. Remember, you have put the implant, you have waited for 2 to 3 months. Why do you wait for 2 to 3 months? This is the bone remodeling cycle. These are the four phases that they are going on, and you are now entering into the primary mineralization phase where you will load your two-piece implant that is placed in the alveolar bone. You are bypassing all these activities when you are engaging your implant in the cortical bone. You do not have to wait for 2 to 3 months for the primary mineralization to happen. Your primary stability is not going to come from the alveolar bone. Your primary stability is from the cortical bone, in which this process will go on. You have triggered this process in the alveolar bone because to reach the cortical bone, you have done osteotomy through the alveolar bone only. This process will go on, but you have engaged your implant in the cortical, you have gained the primary stability, you have managed to avoid the micro motions by giving the rigid splinting effect over the abutments, and then you have managed to reduce the micro motion below 6 microns. This process will complete itself and this will help you give the secondary stability. This is the biomechanical stability. The secondary stability is the bone reaction towards the implant. You need secondary stability for the longer life of your implant. You cannot just depend upon the cortical. You cannot just depend upon the primary stability for the longer life. You would ultimately want the bone to react with the implant surface. Even though you are not worried about the osseointegration in the initial 2 to 3 months, you might end up with a little bit of fibrous union, but you are not worried because that does not hamper your long-term process, because osseointegration is ultimately going to happen on good implant. If you have given good bone to implant contact, the secondary mineralization process, which would take about 1 to 2 years, this is going to take care of the implant for a longer period of time. Now, the whole game of implantology, it depends upon two things. I want you to understand that doing implantology, doing osteotomy is not difficult. But just to read the type of bone from OPGs and CBCTs, and while you first go ahead with the first drill, with the pilot drill, you need to train yourself. You need to train your eyes. You need to train your tactile sensation that what kind of bone you are trying to take out, and then you put the implant inside that. You need to read the bone. First of all, the bone, the type of bone, it is the first thing that this game is about. And secondly, the force distribution. If you manage to learn how to read the bone, if you manage to learn how to feel the bone, which kind of bone you are going to play with, and then you place the implant and then you load it. If your forces are balanced, if your occlusal forces are diverted equally all around, if your force distribution is excellent, then there is no thing in the world which is going to cause the failure of your implant. You just need to take care of the occlusal forces, the occlusal force distribution, your quad formation, your implant distribution, your AP spread. These are smaller things. The bigger thing is force distribution. If you have taken care of the force distribution, if you have taken care of the type of bone you have, if you have trained your eyes, if you have trained your hands to feel that, if the tactile sensation of hard and soft bone, if you know how to differentiate it, there is nothing beyond it. You just need to learn this. I'm not asking you to go for extensive training. You just need to read the basics. This is there in the Contemporary Implantology by Carl Emisch. This is taken from there. It is very easy to find these kind of articles and research papers, and there is absolutely, obviously, there is more and more research going on on this bone density classification. But this basic D1, D2, D3, D4 bone differentiation, you need to learn it. Now, by just taking the gist of it, just try to understand one thing. The most dense bone is where? It is there in your mandible, in the anterior region. So whenever you drill in your pre-mental region, that is between the two mental foramen in your mandible, this area is highly corticalized, highly dense bone because there is layers of corticalization that there are present in the anterior zone. You need not to perforate anywhere, neither lingually nor buccally nor in the basal bone. You just need to land inside that dense cortical bone and you engage your implant there and you will get excellent primary stability. Your ISQ value is going to go beyond 80, 90, 100, maybe 110. But you do not want pressure osteolysis as well. You do not want your bone to go away because you have put much more pressure that it can withhold. So the threshold of your dense cortical bone is way beyond 100, but you need to keep your ISQ value beyond not more than 85 or 90. You just leave your implant, you just give the primary stability. ISQ, the torque there should be not more than 75 to 80. Now, the anterior zone in the mandible is highly dense. So the more the density, the more the corticalization, the more the mineralization, the more is the torque value in that area. That D1 is the densest bone that there could be in your body, in your jaws. Now, D2 is thick cortical, but coarse tubercular pattern is there in that bone. Now you try to, if you have done any kind of implantology in your career, if you have placed conventional implants, if you have done osteotomy, if you try to remember that when you enter from the first lining of the bone, that is the hard cortical, you have to put so much pressure on it for perforating just to get that entry, just to get that ditch from where you begin your further osteotomy, the drills that you need to widen that osteotomy. That is very easier. Just the first drill is very difficult because there is thick cortical present. Now, beneath that thick cortical, there is alveolar bone, which is trabecular cancellous bone. And the pattern of that bone is such that you do not need to put much pressure. You do not need much torque to go through that bone. That is the D2 type of bone, and it is present in the posterior mandible or the anterior maxilla area. Here you get good torque from the cortical. I'm not talking about the alveolar bone. I'm talking about the cortical bone. You get good primary stability of 65 to 75 or maybe 80 or maybe 90. And then you can load that implant immediately if you have engaged the cortical bone. Now imagine more spongy, more cancellous, more trabecular pattern and thin corticals, which is present in the posterior maxillary region. Sometimes there is anterior maxilla is also very spongy. In some cases, there is resorption, there is osteoporosis, there is loss of alveolar bone. That area tends to get very thin corticals, very fine trabecular pattern, very spongy bone over there. And what is D4? It is completely spongy bone. There is minimal cortical present, and most of the times it is the posterior maxilla region only or the maxillary tuberosity only. This is the least dense bone. You need to learn how you feel that bone. When you do osteotomy, when you enter the bone, you need to understand the tactile sensation of hard and the spongy bone. If you learn this, there is nothing beyond this. You will be able to understand what kind of implant design you want to put in that bone. Now, I want you all to understand that not a single implant design is meant for all the bone types. Or if you want to lodge that single implant design in all kind of bones, you need to change your osteotomy style for every bone type. Otherwise, I would urge all of you to do research and find different designs for different density of bones. This is only wise to do on our part because the companies tries to sell you the same implant design for all bone types. Technically, there should be different implant designs, different the shaft designs, the different thread designs, so that wherever the compression of alveolar bone is required, like the lesser dense bones, the spongy bones, the D3, D4 type bones, we need to compress the alveolar bone. We need to do lateral compaction of the alveolar bone to generate the primary stability and increase the bone implant contact. In dense cortical bones, you do not need much wider implants, or if you want to lodge that wide implant inside your cortical bone, you need to do more aggressive osteotomies. You need to remove a whole hell lot of bone to lodge that wide body implants. So I think I have covered most of the cortical bone. This is a version system. We have all read about it. The woven bone that I've told you that the first in initial 72 hours, there is blood clot formation, there is a fibrin scaffold, the inflammatory phase starts, and then the osteoclastic resorption of bone starts. On the day 3 to 14, this is a rough idea, this is not the exact same time. Then the initial 2 weeks, there is deposition of soft woven bone. That woven bone ultimately gets converted into the lamellar bone. The woven bone is the soft bone, which is there in our embryonic stage as well. Woven bone ultimately gets hardened, gets more mineralized, get the Haversian pattern inside that woven bone tends to settle down in a more parallel way. It becomes more dense, and hence the lamellar bone replaces that soft woven bone. Okay, and then full eversion remodeling is complete, primary mineralization is complete, the bone maturation is complete within 3 to 12 months. 3 months is the primary mineralization phase, 12 months is the secondary mineralization phase, which will help your implant to get the secondary stability, the biomechanical stability, which would come after primary and secondary mineralization only. Now, where are these? I have been talking about cortical all the time. And you must be imagining where are these corticals? Now, imagine if you have seen any zygomatic implant placement, what is that? The zygomatic in itself is a cortical. If you have seen any surgeon placing this zygomatic implant, they perforate the zygomatic bone just to make sure that your implant is going to lodge in that cortical. And if you engage that cortical, you must have seen that there is tremendous torque, and they would want your implant to be loaded immediately. They would always want that forces are going to go inside that cortical, and that cortical would thicken as a is in the anterior zone, the nasal floor cortex. That nasal floor cortical bone, it extends from this inferior floor of nasal cavity towards the posterior palate. You can access this nasal floor from the anterior zone also, and from the sinus zone also. The sinus is corticalized, this pneumatized below the nasal floor cortex. The sinus is never there beyond the nasal floor cavity. The sinuses are buccal and below the nasal floor cortex. You can engage your nasal floor cortex by going transsinus approach as well. But most of the time we engage the nasal floor cortex through the premolars, canines, and the anterior region only. This is the most stable floor, and the highly corticalized mineralized bone is there to give you primary stability. Now, most of the times D1 to D2 bone is present here. Cortical bone is always D1, D2. So the alveolar bone over here would also be a little bit more thick. D1, D2, D2 to D3 bone is there in the alveolar region. This gives excellent dense cortical engagement, and it would provide you with 70 or maybe more than 80, 85, 90. I've seen, I've got more than 100 ISQ, the NCM torque in this region as well. Second is the piriform rim. This is in the piriform area, the canine fossa area, the piriform rim area. This is highly corticalized. You can engage your implant here as well. Now, the lateral nasal wall cortex. When you go from the premolar region, instead of engaging the floor, you tend to engage the lateral nasal wall most of the times. This is a highly cortical, then again, this is a highly corticalized area. Good engagement you get, and this is kind of multi-cortical engage because you go through the sinus, or maybe with anterior to the sinus wall, you are engaging that sinus wall as well, which is a kind of cortical, and then you are perforating the nasal wall and you are engaging that wall as well. So this is kind of a multi-cortical anchorage area. Palatal cortex, we all know, if when we extract a tooth, we go palatally so that we can engage that hard palate area. So that is also a cortical bone. The pterygoid cortex, okay. I've talked about the zygomatics. Now, uh, when we do full arch rehabilitations in maxilla, sometimes we are not able to place implants in the sinus area. So what we do, what is the all-on-4 concept that we do? We try to increase the AP spread by tilting the implants, the posterior most implants. Still, we have to give cantilevers most of the time. Now, this pterygoid, which is there behind the maxilla, it is a thin, not that thin, but the bone density, the cortical plate thickness is about 2 to 6 over there. You engage your implant over there and you completely eliminate the need of cantilevers. You can load up to the first molar area. You give a wider occlusal table to the patient. The patient enjoys chewing more with the distal most molars. If you just give bite till the premolars only, that chewing becomes more difficult. There is more muscular straining that is happening if you chew from the most anterior zone. Okay, just to eliminate cantilevers. This, if you are able to engage two implants in the pterygoid area, you might not even need that zygomatic implant. Sometimes you eliminate the need of zygomatic implants by giving two pterygoid implants. Zygomatic cortex, now it is a far buttress. Zygomatic buttress is the far cortical from the maxilla. The extra maxillary cortical is the zygomatic cortical. When you engage your implants in the zygomatic cortical, you take most of the pressure. The most of the occlusal forces that are directed towards the maxilla, they are directed towards the zygomatic if you have given zygomatic implants. In some cases, you might need to give two implants on each side. There is a concept called ZAGA, zygomatic anatomy guided approach. There are different trajectories, different lengths from which you can engage the zygomatic cortex. But when you do zygomatic engagement, you take most of the load away from maxilla. Hence, your maxillary atrophy, maxillary resorption becomes slow. More of the pressure is directed outside the maxilla. The forces are taken away from maxilla. Hence, your maxilla is severed. The maxilla is saved. The maxilla lives longer. Canine pillar and frontal process of maxilla is again near the canine fossa and the piriform rims. The sinus floor cortex. Okay. There are two types of corticals. One is the stable corticals and the another is unstable corticals. Now, the sinus floor cortical is kind of unstable cortical because we all know that the sinus floor tends to pneumatize throughout life. The atrophy in maxilla is bidirectional. It's from the tooth, from the roots surface. First direction is from roots upwards, and second is the sinus floor downwards. The maxilla reduces in two directions. ऊपर से sinus pneumatize हो रहा है, नीचे से crestal bone loss हो रहा है. This ultimately ends up in bidirectional loss atrophy. So the sinus floor cortex is unstable because sinus is going to pneumatize throughout life. So you cannot completely depend upon this cortical, but this cortical gives you support so that you do not have to give pontics, a longer pontic area in the posterior maxillary region. If you are going to load your molars, you need some kind of support in that bridge. Imagine your distal most implant in the premaxilla area is in the first premolar region or in the canine region. and then your pterygoid implant is exiting at the 8 or 7 region, the second molar or the third molar region. That pontic area becomes too long span. So to eliminate that long span area, you engage your sinus floor cortex, the anterior wall of sinus, the posterior wall of sinus, the floor of sinus. These are all corticalized, but this cortical is very thin, very unstable because the sinus pneumatizes throughout the life. Anterior nasal spine is again one highly corticalized area. You can engage your anterior implants in the anterior nasal spine to get the primary stability, and then you can load your implant when there is alveolar bone loss. Okay. Then cortical bone around incisive canal. This is one more cortical bone, but you do not need to engage this bone if you have good nasal floor engagement. Tubero-pterygoid implant. Now, this is very interesting. When you lose the maxilla, there is loss of tuberosity as well, most of the time. But sometimes you see tuberosity and you have the pterygoid. So if your implant design is such that it is compressing the tuberosity and then going inside the pterygoid, it is called a tubero-pterygoid implant. But if you have done extraction, immediate extraction, and you are placing an implant in the pterygoid area, your most of the implant shaft is going to be in the socket or in the sinus. The distal most, the apical most part of the implant that is going to engage the pterygomaxillary region, it is just 2 or 3 mm thick. So most of the implant is going to be in the socket or the sinus area. So that is called a true pterygoid engagement. But if there is tuberosity and you are going through the tuberosity and you are compressing and taking advantage of the tuberosity as well, that becomes tuberopterygoid. Now, I have told you about all these corticals. In implant approach area, you have to engage at least, if you are placing single piece smooth surface implants, you have to place at least 4 to 6 implants in the nasal floor or the piriform rim area. Then you put at least 1 to 2 pterygoids. If you are able to put single good pterygoid and you put one support implant in the sinus floor region, there is no need of another implant engagement. There is no need of zygomatics. There is no need of grafting. You can do IFL, immediate functional loading, immediately, and you can load those implants within 24 to 48 hours. If you are able to print your processes, if you are doing intraoral welding or syncrystallization, you can load it on the same day. And then if there is severe atrophy, you are not able to, engage the nasal cortex through the premolar region as well. You are just able to put 2 implants in the nasal floor. Then you go for the zygomatic implants. If your sinus is pneumatized anteriorly, mesially so much that it has come to the canine area, you cannot place implants. You might not be able to place implants through sinus. Then there is the need of zygomatic implants. And to reduce the posterior cantilever, you go for the pterygoids as well. Even then, there is no need of sinus lifts. There is no need of grafting. There is no need of ridge augmentation. You can go ahead and load your prosthesis immediately. In the posterior maxillary area, if you want to give, segmental restoration, you can engage your pterygoid, or you can bypass the premolars and engage the nasal cortex, or you can go through the sinus and engage the nasal cortex, or if there is lesser pneumatization of the sinus floor, you can engage the sinus floor as well, and then you can give segmental restorations as well. Now, 1 to 2 implants in the sinus area, 1 implant on each side in the pterygoid area. That comes to around 10 to 12 implants in a edentulous maxilla. Now, we have talked about maxilla. Let's talk about mandible. We are short on time, I understand, but please, just a few slides are left. Try to imagine the things. Now, mandible, I've told you that there is if you want to engage the cortical, you have to perforate the cortical in the posterior mandible area. Just to make sure that you have landed in that cortical, it is mandatory to perforate that cortical in the posterior mandible only. in the interior mandible, there are various reasons that you should not perforate the mandible. One of those is there are layers of corticalization. You don't need to perforate those, the basal floor. There is lingual artery attachment in the lingual side of the anterior region, so you don't want any bleeding in that floor of mouth. Buccally, you do not want to come out because it might hamper your aesthetics. You just want to stay inside the bone in the anterior region. In the posterior region, you have two options or maybe three options. One is the buccal cortical, one is the lingual cortical, and one is the basal cortical. For engaging the basal cortical, you have to bypass the inferior alveolar nerve. Buccal cortical engagement is mostly possible when there is good height of bone present, or if you are going to engage your implant in the 7 or 8 region. Lingual cortical is the region where you engage your implant in the first molar region or the second premolar region, and you get high torques in this area because this concavity below the mylohyoid ridge is highly corticalized, highly dense, and highly mineralized area where all the muscle attachments are there. This is the reason of thickening of cortical, and you take advantage of that thickened cortical and you engage your implant in that area. Basal cortical, again, I've told you to reach that basal cortical, you have to bypass the inferior alveolar nerve. Because in order to reach the inferior border, the lower border of the mandible, there is going to be neurovascular bundle that is going to hamper your pathway. So you need a CBCT, you need to locate where that neurovascular bundle is, where is that IAN bundle is, and you bypass that area and you reach the basal cortical. Again, I want to tell you one thing that there's a very big misconception in the market. We are calling some implants the basal implants. I want to clear the air that basal or the cortical is the bone. If you engage your two-piece implant or the hybrid implants or the conical implants inside that cortical or basal implant, would you call your implant a basal or cortical implant? No, you will call that two-piece implant. So implants are categorized into either smooth surface or rough surface, two piece or single piece. Basal and cortical is always the bone. Now I've told you in the anterior region, in the symphysis or parasymphysis cortical region, there is no need of perforating the mandible, and it is present between the two mental foramens. You locate those mental foramen on OPG or intraorally, and you engage anywhere between this at an angle so that you can increase the bone implant contact by increasing the length of the implant. This is the safest area if you end up in between the bone only. External and internal oblique ridges are landmarks from where you understand where your first implant is going to be. Mylohyoid ridge, I have told you the lingual plate, the lingual border, below the mylohyoid ridge, there is high corticalization, high mineralization, and you engage your lingual cortical over there for the molars and the premolars beneath the mylohyoid ridge area in the maximum concavity area. Okay. So take a screenshot of this page. This is very helpful when you do full mouth cases, full arch cases in mandible as well. Now see, the density in most of the areas D1 and D2. Okay. So physiology and biological foundation, I have explained it to you very well. The remodeling, the response to loading and unloading, the response to implant, the response to any kind of stimulus, how the bone reacts. Okay, this is very important. Even though I've told you most of the things, so just go through this. We need primary stability for what? This is the mechanical interlocking of threads in the bone. You take the primary stability from the cortical engagement by doing osteofixation. You depend upon osteofixation, and then you expect osseointegration and osseoadaptation in the future. How would you expect that? By reducing the micro movements, by rigidly splinting your implants. And if you have gained primary stability from the cortical, you are not depending upon the alveolar bone for the primary stability. You let the alveolar bone take care of the secondary stability by osseointegration or osseoadaptation. You engage your corticals for mechanical interlocking of the threads of implant for primary stability. It is highest at the day 0. When you place the implant on the day 1, it is highest. And while the remodeling occurs, I've told you bone resorption and bone formation are simultaneous processes that leads the way to primary mineralization. Hence, while in the period of remodeling, while in the period of resorption, the primary stability declines with time, and ultimately it increases when there is mineralization, when there is bone formation happening. So secondary stability is dependency upon osseointegration and osseoadaptation, and it depends upon bone implant contact. If the primary stability is the highest on day 1, obviously the secondary stability is lowest on at the initial period, because the bone resorption is occurring. Ultimately, bone formation will occur, and then secondary stability will come. Okay. Primary stability is obviously more. It is the ISQ, the implant quotient over here is more than 70. The implant stability quotient is more than 70. And it is definitely required if there is lesser torque, if there is only 30-40 NCM torque in the corticals, you do not want to load them immediately, or you want to change the implant design to get higher torques. You want more compressive threads, more cortical threads to engage that highly mineralized bone and get more torque, or you might need to increase the diameter of your implant. If you get torque more than 60 or 70, then only you can go for immediate functional loading. In the secondary stability, your bone to implant contact is of utmost importance. Then only there is going to be osseointegration and osseoadaptation. After the primary mineralization has occurred, then only you can depend upon the secondary stability, which is called the biomechanical or the biological stability for your longer life of your implants. Okay. Micromotion, I've told you, if there is the lesser the micro motion, the more chances of osseointegration is there. If there is more micromotion, if there is marginal fibrous union with the implant, then it might end up in the failure. If there is motion is happening more than 500 micrometers, then there is definitive chance of fibrous union. Okay, the implant failure will occur if your micromotion is more. How do you negate the effect of micromotion? How do you eliminate the micromotions? By rigidly splinting the abutments. And if your primary stability is coming from the corticals, there is going to be very less micromotion. Bi-cortical anchorage, multi-cortical anchorage can only be taught. It cannot be, you can only be trained on a 3D model or in the patient's mouth. Just by reading it, you cannot get trained by, you cannot be trained in bi-cortical anchorage. So I'll tell you briefly, when you enter from the, let's imagine you are drilling, you're doing osteotomy in the posterior molar region in the mandibles. When you start your drilling, when you mark the point where you have to do the osteotomy, it is very hard. That is the first cortical from which you are entering the bone. After perforating that first cortical, you are entering into the alveolar bone. This is only present when there is edentulous area. Otherwise, in an extraction socket, you might have seen that there is lamina dura, which is a radiographic representation of the bone around the tooth. It is also a very thin cortical. Even then, if you are doing osteotomy in a extraction socket, even then there is a slight cortical lining which you are going to perforate and going to get the bicortical anchorage. Now, how it is bicortical? You are entering from one cortical and you are getting out from the second cortical. You are engaging the basal cortical or the buccal cortical or the lingual cortical. This is called bicortical anchorage. Now, I'll give you one example of multicortical anchorage. Multicortical anchorage is the area. One example is the pterygoid bone region, the pterygomaxillary fusion zone region. There are three bones which are joining in that fusion zone. First is the posterior wall of maxilla. Second is the pterygoid plates which are hanging from the sphenoid bone behind the maxilla. Third is the palatal cortical which is going to merge there. The palatal bone merging inside that pterygomaxillary fusion zone area makes it multi-cortical anchorage. If you are able to engage that tri-cortical area where there are three corticals that are merging, you get tremendous torque of more than 80 or maybe 90, and you might be able to bend your implant as well. If there is no good cortical anchorage, you might not be able to bend your single piece implants as well. And for your single piece implant abutment to be in the prosthetic zone, most of the times you have to bend them because you are going at an angle. For two-piece implants, you will be placing multi-unit abutments. Okay, so this I have explained. Occlusal forces from the teeth, they go into the prosthetic area in the abutment area, and then they finally end up in the implant neck. If there are threads in the implant neck area, they will distribute the stress along the threads in the alveolar bone only. If there are threads in the cortical area only, if there is only plain shaft in the alveolar bone, no stress distribution is going to be there in the alveolar bone. Okay, so I have made this in a very easy way. Even though the I-core is an event, but I'm trying to explain it, the five pillars of immediate functional loading with the ICORE principle. First is the implant design, engineering for the cortical engagement. According to this, so this could be different according to all the surgeons. Might like the design that I do not like for cortical engagement, but our goal, our mission is one only: engaging the corticals for immediate functional loading by taking the primary stability from that dense cortical bone. I like the implant design which would not distribute any kind of stress in the alveolar region and directing all the occlusal forces directly into the cortical bone, because my cortical bone is much more capable than the alveolar bone to take those occlusal forces and to dissipate them along the muscle pathways. Second is the cortical engagement. This is the heart of I-core protocol. If you do not do cortical engagement, you will never ever be able to confidently load your implants functionally. Again, I'm repeating this word functional because you can put an implant in the alveolar bone in the anterior region and you can give aesthetic loading. You can put a tooth over it and you just need to fill that missing tooth area. That is called immediate aesthetic loading. I am talking about functional loading where you tell the patient to chew from the third day only. You do not need to ask the patient to avoid chewing from that area. Now, this cortical engagement can be monocortical, bicortical, multicortical. The remote corticals, what are remote corticals? Zygomatic and the pterygoid bone, which are the far corticals, which are far away present from the maxilla. Occlusal optimization. And now, remember, I told you that the whole game of dental implantology is about reading the bone and your occlusal force or occlusal stress distribution. If you distribute your occlusal stresses beautifully, your implants will work throughout life. They are not going to go anywhere for next 20, 25, 30, 35 years. But obviously do not give warranty to any patient. So, because that is going to fire back upon you only. Rigid splinting is the most important thing. Why I have told you to reduce the micromotions, you rigidly splint the abutments of the implant so that there is no micromotion while the patient chews from those areas. We do not want any kind of lateral forces or any kind of forces that are generated not in the parallel way, which are the forces that are going to affect my crestal bone. I do not want any kind of micromotion, so that all the forces that are coming from the chewing of the food, all the occlusal forces easiest way and the most stress-free way to give the rigid splinting effect over the implant abutments. Second way is you give milled titanium or metal bars over the abutment, and it has to be done within the time frame before the bone resorption activity starts. So the best time of splinting is on the day of implant placements. You do not give a single chance to the patient to put any implant in the The E in I-core is early functional adaptation. I told you we do not ask the patient to avoid chewing food. We ask the patient to chew food and train your corticals so that cortical thickening with Wolff's law that I have explained, that has to happen. So why cortical engagement changes everything? Traditional concept was minimal 10 mm of height, 6 mm width, grafting if the bone is less. The bone requirement for the conventional implant for a two-piece implant. Remember, you have to leave 1 mm bone on the buccal side, 1 mm bone on the lingual cortical side. You have to be away 3 to 4 mm from the adjacent implant, 2 to 3 mm away from the tooth as well. So these concepts are completely revolutionized with the strategical cortical concept. You give loading because you are engaging the cortical bone. In the traditional concept, alveolar bone implants do not take immediate loading because the bone is soft. The bone has to go under remodeling. It needs to take 3 to 6 months. For the mineralization to happen, you need to depend upon the osseointegration only. You do not depend on osteofixation, osteoadaptation at all. And if there is lesser bone height, lesser width, you need to go for bone augmentation, you need to go for ridge split, you need to go for grafts, you need to go for sinus lifts, GBR, whatever, more armamentarium is required, more training is required. Grafts are so expensive that your patient ends up spending more, and sometimes patients are not comfortable spending more on the tooth, so they tend to go for the removable processes. Now, in this cortical concept, you engage long implants in the corticals, you increase bone implant contact, BIC, by tilting those implants. You go for tilted implants, you go for cortical engagement, and there is no or minimal need for grafting. Or there is, if you have strategically placed your implants using the existing corticals, using the existing anatomy, you have been able to identify the corticals and you have engaged those. You do not need any sinus lifts. You do not need any nerve lateralization processes. There no grafting is required. So it is technically easier than the conventional or the traditional concept. The torque is higher. The initial stability, the primary stability is higher. So this is the emerging newer science. So cortical bone engagement is not technically newer, but it is emerging now because it has been read and researched upon from past, I guess, more than 100 years now. What are the take-home messages? Corticals are nature's load-bearing structures. You do not avoid them, you engage them. Immediate loading succeeds because of cortical engagement only. The biology follows biomechanics and the functional loading stimulates bone adaptation. So you do not need to worry about osseointegration. Okay. So you transform your treatment possibilities. You master the science of cortical engagement. You learn the anatomy of corticals. You need to understand the importance of training, because if I ask one this implant surgeon who is placing two-piece implants and I ask him to place this basal or cortical engagement single piece or two-piece implants and go for immediate functional loading, he or she might not be able to understand the concept, and they might end up with the implant failure because they are going to place that implant in the alveolar bone, and that is how they were trained. And if there is no alveolar bone, what would they do? They'll put grafts, they'll do sinus lifts, they'll do nerve lateralizations, they'll do ridge splits to make way for those alveolar implants. Now, if you are not trained in how to engage those corticals, you will definitely end up filling those implants. Then the whole of the this thing that the implants are failing, the basal implants fail, the cortical implants fail, the immediate functional loading implants fail. This whole thing is stacked upon the implant type. Nobody would love to take the claim. Nobody would love to take the blame of the lack of knowledge. So I would urge all of you to take proper training before you go for cortical engagements. And we are giving one opportunity like this in the month of November at Jaipur. We are organizing one great event, ICORE 2026, in which we will be this is one of a kind of event, and it has never happened before in India or outside of India at all. We'll be conducting hands-on master class, and we will be attempting a world record as well, in which we are placing more than 500 implants in 5 days only. So in the initial 2 days are going to be lectures from the world-class faculty. You will be seeing great implantologists who are doing immediate functional loading with two-piece implants, with single-piece implants, with smooth surface implants, with rough surface implant, or there are n number of types of implants there are there in the market. And all of these speakers are going to talk about immediate functional loading, the maxillary anatomy, the mandibular anatomy, all the possible signs of immediate functional loading. And then after those two intensive lecture days, there are going to be 5 days in which we are going to place more than 500 implants, and we are going to give you workshops. We are going to train you very well for these cortical engagements, and the prosthetic protocols and the 3D printing, everything is there. Dr. Sudhir is also there for the lecture, and he's going to deliver a master class on ozone therapy in general dentistry, or the implant dentistry, or the whatever its application is there in the field of dentistry. So the future of immediate loading lies not in more implants, but in smarter cortical engagement. So I thank all of you to be. You have been very patient. You have listened to these number of slides, and this might sound boring to some people, but uh, this is the need of our. This is everybody needs to learn the science of immediate functional loading, because patients are more demanding these days. Patients want teeth immediately. They do not want to wait for 3 to 6 months. They do not want to spend upon sinus lifts, and they do not want to take any chance that the sinus lift has failed, the bone augmentation has failed, the bone graft has failed, and then again you have to wait for 6 months, 1 year. So I urge all of you to learn the science of cortical engagement and start doing immediate functional loading, even if it's a single tooth or a single arch placement or full mouth cases. Thank you so much. Thank you. Handing over to you, Dr. Sudhir.
Yes, sir. Fantastic session. Wonderful presentation, sir.
Thank you so much, sir. Thank you.
Definitely, theory is required, and all the slides were very helpful. I hope for everyone who attended this webinar. I request every one of you doctors, please, if you have any questions, you can ask in the chat, or you can switch on the camera and your audios one by one, and you can raise your hand also. And please go on with the interaction with the one-to-one with the speaker, please. Anyone has any questions?
I'm sure there will be a lot of questions, but I would like to answer the questions according to the situation only, because I cannot give the whole knowledge in just 1.5 hour. It's a very big topic. I need at least 3 to 4 days to cover the theory of this cortical engagement and anatomy of everything.
Yes, sir. Okay, something there. One doctor has praised you, sir. That is a wonderful session. And
Thank you so much, sir. Thank you.
yeah. So anyone has any questions, or we can wind up this session. You can also, you have joined the group from where you have joined this webinar. You have joined that group. Be there. We are having a webinar of series webinar for this basal implantology, corticobasal, and immediate functional loading, and so many protocols are there to be presented by today's speaker, Dr. Abhaydeep Singh. More speakers are there, Dr. Kanak Parikh sir, Dr. Ayush Srivastav, Dr. Vishwas Sharma, and and more speakers are there who will be presenting more webinars for this specific implantology series of webinars. So you can join the group. That group is permanent there for this specific webinar series. You can ask your questions also there. I urge to you all that please put your cases in the group or interactive with the speakers, or you can contact them in person also. Everyone is very dedicated. Even all the other mentors of the ADC, they are also very dedicated. You can contact any speaker in person also and in group also.
So there are
One question
two
is there.
questions that are there in the chat. I've just read those questions. The first question is any contraindications of basal implant? First of all, any kind of contraindication that is there for any kind of surgery in your jaw. It could be maxilla, mandible, single tooth, multiple tooth segment, or full arch. If there is any kind of metabolic disorder in osteoporosis cases or in cancer patients, you need to consult the physician first, and then you can go ahead with the surgery. And secondly, the contraindication is if you are hardcore screw retain prosthesis lover, then you cannot go for the single piece smooth surface implant. For the single piece compressive implant, single piece rough surface implant as well. This is the only thing that you need to consider for the basal bone engagement with single piece implants. Otherwise, it is same as other surgeries. For the single tooth replacement, someone has asked, you need to understand the science that for single tooth you need more BIC in that single implant only. If you are trained enough to place two single piece smooth surface implants, then you can go ahead and do immediate functional loading. If you want to increase BIC with different design of implant, you can go for compressive internal hex implant. You can go for compressive implants. You can go for there are you need to go for the conical design to engage the cortical. There are various companies in the market. I would not like to name any one of them, but you can just Google and you can find it. There are n number of companies in the market which provide conical implants for their screw retain prosthesis for a single tooth replacement as well. And another question is there for edentulous upper molar, can we replace it with basal? Please try to understand basal is the bone. Be specific for which kind of implant. If you are trying to ask single piece implant, yes, you can do edentulous upper molar. You need to understand the anatomy. You need to train yourself how to engage the palatal cortex or the sinus floor cortical, the unsupporting the unstable cortical, and one implant in the palatal cortical. If you are asking for single piece implant, you need to place two implants for one tooth. If you're asking for rough surface implant, you can go through the sinus as well. But you need to train yourself for that. You just cannot say that I have placed more than 100 of conventional two-piece rough surface implants and I can load it that implant. If you start using this single piece or compressive implants and you just place it in the alveolar bone and load it immediately, this cannot happen. If there is sinus pneumatization, you need to learn sinus lifts. You need to understand lateral windows. You need to understand indirect sinus lifts. If you want to engage the cortical for immediate functional loading, you can bypass all these protocols. You can bypass all these procedures. Learning this science, this cortical science is a very different field from the conventional science. So it cannot be done with your previous knowledge of two-piece implants. You need to unlearn the first science and then relearn or learn this new science for cortical engagement. I hope you understand my concept. Any other questions, please ask. Right, you're welcome, sir. Handing over to you, Sudhir, sir. Please continue. Sorry for interrupting you.
Yes, sir. Anyone is asking any questions, please let us know or we can finish the session. And thank you everyone for attending this session. Please join in the group. Once again, I am requesting you all, as well as this webinar is recorded and it will be posted on YouTube channel of the Academy. but not all webinars will be posted. So I request you please attend all the webinars of the this series and as well as other webinars to be presented in ADC Academy through online Zoom meetings. So see you in the next webinar. We are having on the last Sunday of June, again to be presented by the same speaker, today's Dr. Abhaydeep Singh. So see you next in the next webinar. Have a nice time. Have a nice time for today's Sunday. Uh, okay, we'll finish.
All right, everyone. Thank you so much for your patience, and I hope you enjoy your Sunday to the max. Thank
Thank
you.
you, sir.
Thank you, Sudhir sir, for giving me the opportunity for
Yes, sir. Pleasure, sir. Pleasure.
sharing the screen with you
Uh,
is always a great pleasure. Thank you so much.
yes, sir. We'll go move on with more webinars. Thank you. See you.
Absolutely. Thank you.
Okay.